Hello and welcome. I will focus on child language disorders and language delay. So my speech is shaped around three questions: what, why, and how. In the first section, we're going to focus on inconsistency in terminology of child language disorders, and then we will focus on the underlying causes for language disorders. And on from here, as a language and speech therapist, I will focus on this theoretical information. How can we move this theoretical information to daily practice for our treatment? Looking at child language disorders, we come up against very different terminology. Language disorder, language impairment, late talkers, late language emergence, late bloomers, language delay, expressive language delay, language impaired children, developmental language disorders are all the phrases used for defining this disorder. And we're going to focus on this research. Between 1994 and 2013, all trials evaluated in Google Scholar were researched, and 168 different combinations were found, and 130 of them were at least used once, and 33 distinct terms were used 600 times or more during that period. And the most frequently used label was a definition like specific, primary, or secondary. So I'm going to focus on language, speech, or language learning. What are the alternatives? Which word should we prefer? Mostly language was preferred, and in the name also was the disorder, was the problem, was the challenge, and mostly disorder were used. So when we look at the prefixes, descriptors, and nouns, we see that the ones in red have been used, but there seems to be an inconsistency in this terminology, and it makes differential diagnosis go different ways and with different legal rights, with different treatment techniques. And in a multidisciplinary framework, we see that people from the education side use a different terminology when compared to people from the medical side, and also evidence-based studies need to be developed, and it still causes problems. So the first thing to do in this area is to clarify and ascertain the terminology. And in 2017, a consensus trial was conducted, and the main problem here, or the main issue here, was that it required a multidisciplinary perspective. As you can see in the table, speech therapists, psychiatrists, psychologists, audiologists, and child developers were all included as panelists, and this trial contributed mainly in two ways to the literature. First of which was achieving a consensus on the terminology, and secondly, a flowchart showing pathways to diagnosis of language disorders was formed. So, in terms of consensus, was the preferred term. It was said it should be developmental language disorders, but this is obviously a subset of language disorders, and language disorders need to be evaluated in a much larger scale, it was said. So speech, language, and communication needs need to be evaluated. Dysarthria, verbal dyspraxia, articulation disorder, or facial structural deficits, voice disorders, fluency disorders that might result from them, and language disorders associated with biomedical conditions. And also further areas of impairment need to be evaluated, like syntax, morphology, semantics, word finding, pragmatics, phonology, discourse, etc. Second point that was emphasized was was not a very homogeneous area. There are many underlying different factors, and generally speaking, subsets were listed, or subtypes were listed, and the nature of language impairments were also listed. Risk factors and co-occurring disorders were also identified, and these sort of definitions or distinctions were not really necessary, because we're not talking about a homogeneous area. Every child has different aspects, and there are many risk factors contributing to this, such as gender and prenatal and postnatal problems, the child, male gender, low level of parental education, and also lack of attention, lack of motor skills. So, what about the flow chart for diagnosis? And the first point to start was analyzed so that the disorder must affect the child's daily life in terms of speech. In other words, the thing was to exclude environmental factors, but global factors, changing world, and if a child is living in a bilingual environment, then he can obviously adapt to that language, and that was the question we had to ask. If the child is unfamiliar with local language for certain reasons, like for example the Syrian children in Turkey, so we have to ask if the child is competent in another language. And if the child is competent in that language, then no neuroscientific language disorder is thought to be present in that child, and the patient or the child should be within the need of speech and should be supported in that way. However, if the child is not competent in the main language, mother tongue, or the child can be monolingual, and this is not a disadvantage, or this doesn't mean he's living in an isolated area. So, if the child still has problems expressing himself in the local or other language, then we should look at features likely suggestive of bad or poor prognosis. The feature suggestive of poor prognosis was stated, and what was meant here was general features. So, what are the traits that we can classify a child as under language disorder? So, we should look at possible prognostic features and red flags. Problems in expressive and receptive language skills, and having less than 50 words at 24 months. An absence of production of 2-word utterances at 24 months, like very basic wording, and deviations in the use of communicative gestures between 15 and 36 months, lack of imitations, poor social responsiveness, and potential family history of language or literacy problems are possible prognostic features or indicators. So when we count all these, you might think of autism or other issues. So what the consortium wishes to say here is, first we have to place very basic features, and we should look for the reasons for these basic features. We can say that there's a language disorder in children with all these features. The first question we need to ask is, okay, these children have these traits or features, but is it because of a syndrome? Is it because of a biomedical situation? If it is, then a different terminology comes up, and Is it related to autism, for example? Is it related to Down syndrome? The key thing here is to understand that there's a complex syndrome, and as a result of the syndrome, language disorders might occur. So you might then move on to differential diagnosis. In these situations may result from harm, cerebral harm that occurred in the childhood, or other issues regarding to hearing, autism spectrum, Down syndrome, or intellectual disease or disorder. So what we can say generally for them is the language disorder reasons might also be genetic, but we also have a different group of children apart from them with those general characteristics, but no diagnosis has been given, or the child's condition is unknown. So if there's no biomedical condition, then what happens? And a new terminology was presented, developmental language disorder, which was case of language disorders with no known differentiating conditions which persist into late childhood and adulthood, and the core problems are in linguistic abilities, starting from early childhood to late childhood to puberty to adulthood. The word developmental means emerging in the course of development. But this word developmental needs to be perceived very carefully. It doesn't mean child might get better off or grow out of the problem, and does not mean the child is totally unable to develop language skills anyway. So there were a lot of trials supporting this idea, and children with low nonverbal IQ, not meeting the criteria for ID, can be included in the cases of developmental language disorder. And this trial gives us a lot of crucial findings, but in spite of that fact, in some areas it is still criticized. First, language delay is never mentioned, and the term language delay is regarded as confusing and even unnecessary by our consortium members. But language delay and late bloomers are important for differential diagnosis and prognosis in clinical setting, and the word primary is not a word commonly used to indicate causes of language disorders, and that is due to issues in linguistic aspects of the language. For me, calling this disease primary means, or should mean, that okay, this child has a language disorder and it occurs not for any genetic or other reasons. So I'll give you a classification. Language delay is something we have to use. It's something we can't miss, we can't skip. And consortium members here have had a flow chart, and if we adopt it again, yes, these children have general characteristics that were previously defined, and 24 months is not very early, and all these children at 24 months can be specified as delayed language learners, because know that in some children might develop late and others might develop early, so we have to give the child the opportunity, and we're acting very sensitively. So the language delay problem, not disorder, issue or problem, so we're not making any criticism here. So we're thinking that the child is in a certain specific situation or condition. If these children show an extreme amount of explosion of using words and phrases, and if they catch up to their peers at 35, 36 months, then we call them late bloomers. However, after 35 months, if language problems persist in the child, we call it persistent language disorder. And at this point, developmental language disorder terminology comes in. And developmental language disorder is also asked the same question. Is it because of a biomedical condition? Yes, no. If it's yes, then we call it secondary language disorder. If it is no, if the answer is no to that question, then we say it is a primary language disorder. At this point, if there's an autism, Down syndrome, or other diagnosis in place, then in differential diagnosis, obviously these children have a different place. But in developmental language disorders, are we going to talk about primary language disorder or a late bloomer? Is it possible for this child to catch up to his peers? Prognosis is weak or poor due to the heterogeneity of underlying causes of language disorders. There are some trials, and according to these studies, we know that the prognosis, the strength of prognosis may increase as the child ages. There are some golden questions for prognosis. 1. Which language profile predicts whether children will catch up to their peers by overcoming the phenomenon of late bloomer, or whether they will be at risk of persistent language disorders? As a clinic linguist, I'd like to focus on this framework of Bloom and Leahy and the taxonomy of language. They say that language consists of 3 sections: semantics, the meaning; secondly, the form section, phonology, syntax, and morphology; suffixes, prefixes, and line of sequence of sentences; and use, pragmatics. How do we use the language in social circles? So these 3 give us great clues and cues with regard to the children's ability in these 3 clusters. Minimum 50-word use at 24 months is crucial for meaning. And for the phonology and morphology, 2-word combinations at 24 months is crucial. And use of communicative gestures is crucial for pragmatics. At this point, let's talk about prognosis. On meaning and form, what is our logic? Firstly, for a child to learn a single word and then come up with phrases and sentences for acquiring an adult language skill, very basic thing here is the object permanence, symbolic thought and symbolic play skills. Actually, they can use language skills to describe the objects they see outside. So what they do here is they see this apple, and then they create a mental concept of that apple. And then there's a sound that corresponds to this concept. A-P-P-L-E, apple. And when these symbols come in, the first step of mental side of language is completed. After this, child starts learning his first words, and first words are expected between 15 to 18 months. After that, we look for first 50 words between 15 and 24 months. First 50 words is crucial for language learning, because after 50 words we think that the child is at a high cognitive level, and first syntactic and primitive word combinations begin. Two words. So 50 words and combination of 2 words at 24 months are crucial with regard to identifying whether children will deviate from their peers or will become late bloomers when it comes to speech. But that is not enough on its own. We have to look at the use and number of gestures. The use of language is crucial. So we're looking for a functional approach here. Developing communicative intentions between 15 and 36 months might provide a potential predictor of later language competence, like a child saying instead of no might prove that there might be a developmental language problem. So attention and joint attention development and requesting for an object or extending for an object, then drawing attention, responding, requesting for an action again, and commenting, interpreting. So at 13 to 15 months we're expecting basic gestures for requesting an object, and then between 15 to 18 months we expect minor vocalizations. So it might be that initially the child may say give or so these sounds may follow the pattern of using more words and less gestures from 18 months onwards, and that is what we expect. But if these mimics, gestures and intentions of communication are used more than words and excessive, this might be a predictor for late bloomers and primary developmental language disorder. If the child uses more than 20 gestures in an excessive manner, these children will either be late bloomers or a candidate for primary developmental language disorder. And in the other group, lack of both gestures, meaning less than 20, and verbalization at 18 months, might be a candidate for secondary language disorder that might be related to autism. So what are the underlying mechanisms? And we'll look at some theories here. Lack of gestures lower than 20 might mean that there could be a problem in establishment of symbolic representation of language. So that symbolic representation cannot be formed or established in the mind. And the second step, if there's excessive use of gestures, gives us two alternatives. Either symbolic representation of language is stored, but they're not flexible enough, or they can't access the result. There's a problem of retrieval. So types of gestures are researched or studied. So is it a symbolic gesture or non-symbolic gesture? Pointing is non-symbolic, because there's a direct correlation between the action and pointing, and the child saying in our culture it means no, or using his finger doing this, meaning very good, is a symbolic meaning for us. For late bloomers, they usually use symbolic gestures. However, in the following years we see that primary DLD candidate children use more symbolic gestures. And the basic reason for that is that symbolic representation of language is stored but not matured enough to be modified into various contexts. For primary DLD children, symbolic representation of language is stored, but retrieving that from the storage is the main issue. So working memory problems might even be discussed in these cases. But as I have mentioned, this is not just one diagnosis. We're talking about diagnostic candidates here. Therefore, these are very new, novel researches that have been carried out in the last decade. And for prognosis, we know that the predictors vary with age. Last 5 minutes, please. We know that under 3 years, prediction is rather hard, but Bloom-Leahy's taxonomy classification can be rather useful. And at 3 and 4 years, the greater the number of areas of language that is impaired, the higher the likelihood that the problems will persist into late childhood or school age. And we could be talking about perhaps some permanent DLD. And at 5 years and over, we are expecting poor academic attainment and risk of reading problems. But language is not just three-dimensional. There are also other social factors, environmental factors, and also cognitive skills that are used for execution of language skills. All affect the language. So a good speech therapist might or should know the underlying causes and how they could be intertwined with each other. And these disorders can rarely attribute to just single cause. There might be more than one causes. And in our clinical practice, all these theoretical information is conducted within the frame of this triangle: perception, attention, and then checking executive functions together with social interaction and behavior. So all these factors are coming in or combining for assessing the language, and we also use language batteries for evaluating the language skills.
Disiplinler ekibin bir arada çalışmasını gerekiyor. Bize gelen çocukları
And these children are also sometimes referred to ENT or other departments, and they profile in the end. What we do is that both objective and subjective batteries are evaluated so that some receptive and expressive language skills are evaluated, such as TDIL, TODIL, and TIGE. I'm not going to go into detail because I have no time. And speech act and communicative gesture assessment is also important for using and applying a criteria-based checklist and evaluating cognitive and general development of the children. We have some tests like the Denver non-word repetition or some criteria-based tests. And at the end of it, for a good therapy, all this theory should lead us to a comprehensive evaluation. The more comprehensive the assessment is, the better the intervention for the child. And also, which linguistic aspects are delayed or impaired, which cognitive and social aspects should be associated, and we don't have a standard method. All these profiling should be evaluated, and evidence-based techniques need to be applied. And what is the previous experience and expectations, and there are other issues such as time, budget, dosage, timing, mode. These are all factors affecting the therapy. These are some listed evidence-based therapy techniques. I'm not going to present all of them. We don't have one therapy technique. These are all licensed therapy techniques, like colorful semantics or Macaton or Hannon approach can be applied. And when we apply them, we have their license.
kullandığımız dil ve konuşma terapi tekniklerinin
Obviously, the approaches are either clinician-oriented, child-oriented, or family-oriented, although they may be hybrid, and some of them might be combined, and at the end of the day, all the therapy methods we apply are either behavioral, cognitive, or psycholinguistic. I know I have exceeded my time. Thank you very much.